you think about it, at the International Conference of HIV/AIDS in 2000, there was nothing to integrate. We had no standard approaches to preventing maternal and child transmission, to voluntary counseling and testing, to antiretroviral therapy. There was nothing to integrate. 10 years later, we have standard approaches for all of that. So the conversation is not only possible, but it's essential. Imagine you're an HIV-positive woman. You're pregnant. You got tuberculosis. You've got a child that needs care. You don't want to go one place for your antiretrovirals, another place for your child's care, another place for your TB care, and another place for your antenatal care. And so it's really improving the user friendliness and the patient, family, client orientation of care.
In Malawi, we've integrated TB and HIV. This so happened inevitably because we've had 68% of co-infections, a TB patient being also HIV infected. So because of that situation, that called for an integrated sort of program. The very same patient who is coming to me with HIV problems should also be assisted if they have TB problems, instead of them coming twice to a healthcare worker to get the services.
This program, HIV and TB programs, used to be run in parallel systems and very strong systems. And until 2005, then the decision was made by the authorities in the Ministry of Health actually to integrate these two services for various reasons. You know, the main reasons are, as you know, it's the co-infection between TB and HIV. And in Rwanda particularly, the high prevalence of TB and HIV, and then high co-infection rate, about 30–40%. So it was a good rationale to integrate these two services for the sake of lowering the burden to the patient. 93% of the patients, the TB patients, the TB would be screened for HIV services. And if they meet the criteria to get on the treatment, they will right away be treated in that particular facility for ARV, antiretroviral therapy. And only when they complete their TB treatment, they will be accompanied by the staff to continue the treatment in the other clinic.
Making care more efficient will actually increase the case for funding of AIDS. There's a fear that integration is a kind of a backdoor way of getting out of paying for it. If you make it more efficient, then there's less of an argument to fund it. But actually the reverse is true. As people get familiar with different forms of care and all, it naturally gets integrated.